Okay, so I'm going to be presenting to you now a case on a third-line patient, and this is a patient from the South African third-line program. I just need to just contextualize a little bit. Now, both Lloyd has just commented on this now, and any of you who were at the U=U debate yesterday would have heard Linda Gale in exasperation asking, why is Africa always different? Why do we always exceptionalize Africa? Why do we get drugs here later? Why do we get labs later? Why do we always accept things to be different? And I want to echo that exasperation. And then to comment on the fact that in South Africa, we also have it even more differently. So we tend to have two sets of guidelines running at any particular time, and so it also has its own sets of challenges and chaos. So just to point out that there is going to be a definite bias in this presentation, because this is going to be a patient who's been managed in the South African public sector, and he will have been managed according to our guidelines there. So as in many lower and middle income countries in South Africa, we have 3 lines of treatment. We have an NNRTI-based first-line regimen currently still at this point. We have not yet transitioned towards dolutegravir. A patient who fails first line does not get a genotype done. We simply switch them to a boosted PI and we cycle the nukes according to WHO recommendations. So we tend not to give them the same nuke backbone in second line as we do in first line, unless they've had some comorbidity. So for example, a patient who may have been anemic and could not get zidovudine, we may actually still opt for tenofovir even if they did get it in first line. And we feel relatively okay doing that because the EARNEST, SELECT, and the second line studies have actually shown us it's probably okay, although most of the patients in those studies were in fact cycled as opposed to recycling the nukes. Then if a patient actually fails the second-line regimen, we have a particular little algorithm that we follow that determines second-line failure. And once they fail second-line, we do actually do a genotype to determine what third-line regimen we're going to give a patient. Pretty much everybody on third-line gets darunavir. They get 2 nukes with darunavir, and then we may add in dolutegravir, we may add in etravirine, depending on what the genotype actually looks like. And this applies to adults. The pediatric patients are managed similarly in third line, but some differences in how their actual additional drugs are chosen. But generally, the pediatric patients largely also get darunavir, although some of them are also put onto holding regimens just until adherence and social issues can be addressed. So we saw this slide a little earlier, and just a reminder that the way things are moving, we're starting to see more and more of dolutegravir appearing. It's now a recommended option in WHO guidelines as opposed to 2016 when it was an alternative option, and that we're seeing dolutegravir appearing in first, second, and third line regimens. To date in South Africa, we are only using dolutegravir in third line, although the rollout in first line is imminent. Okay, so let's actually get on to the patient. So our patient, we're going back to 2006. It is a gentleman, Mr. D. He's a 45-year-old security worker, newly diagnosed with HIV, often does a bit of shift work, and he is tested during a hospital admission for acute gastroenteritis with acute renal failure. So we can see his CD4 count is pretty low, his viral load is pretty high, and we're okay. We're not too worried about his liver, looking okay at the moment. So what would we have started with? Well, in 2006, we were still actually on our first set of guidelines for HIV in the public sector. And so what you needed to do to actually start ARVs back then is you had to have a CD4 count less than 200, with which he qualifies, or a WHO stage 4 AIDS-defining illness. And the patient, this was always a very strong criterion initially, patient prepared and ready to take ARVs adherently. So what did we start with? Well, we had 2 regimens that we had as first-line regimens back in 2003. These guidelines came in. Because of the nature of the patient's work, being a shift worker or being a security guard doing some shift work, we opted to put this particular patient on nevirapine, and the backbone that we were using in the early rollout of ARVs was in fact a stavudine-based backbone. Of course, we don't actually use stavudine in our public sector program now. It's been phased out a few sets of guidelines ago. And so we duly start our patient onto his ARVs. So we start him on D4T, 3TC, and nevirapine. 3 weeks later, he comes back to us. He's got an itchy maculopapular rash on the limbs, on the trunk. No mucosal lesions were noted, but he wasn't feeling so good, and really not much going on the physical examination. But when we did some assessment, he was mildly pyrexial, but his ALTs had gone up. Viral hepatitis studies were negative. It was fairly early in those days for us, and we're a little bit twitchy. The question is whether or not we really thought it was a European hypersensitivity. Well, based on the guidelines at the time, what we did was we stopped all the ARVs and we stopped his cotrimoxazole as well. The ALT settled quite quickly on the interruption of drugs, and we just tweaked his regimen slightly, removing the nevirapine from the picture and substituting it with efavirenz. And he tolerated that regimen pretty well. The problem was, because of the nature of his work, the shift work, we did find that maybe his adherence wasn't what we would have liked to have been. So the question is, should we really have actually stopped the nevirapine? Should we have pressed on? And was it really a nevirapine hypersensitivity? Nonetheless, this is how he was managed. So if we have a look at his progress, what you can see is actually he did manage to suppress nicely. We had a period of loss of virologic control when he was diagnosed with concomitant TB in September 2007. He suppressed after that, but then he lost virologic suppression again. And what we can see is by April 2010, a very, very high viral load. So clearly he was not able to take his medication, and he had virologic failure. Okay, so what I want to ask you now is what regimen you would have particularly chosen now to move this patient to. So he's come from D4T, 3TC nevirapine, and I'd like to know which regimen you would like to choose. And please select only one. So, and bearing in mind that I'm talking about a patient who is managed according to older guidelines and what we had, but you have more choices now. So I'm interested in getting what your opinion is and what you would do with this patient if they were in front of you now. I'm also not going to give you a right answer for this. I'm interested in your opinion and how you would do. So we've got a couple of options here. We can use dolutegravir with a Truvada-type backbone. Would we use dolutegravir and rilpivirine, so Juluca, a dual therapy regimen? Would you like to use ritonavir boosted darunavir with a Truvada backbone? What about atazanavir, boosted atazanavir with a combivir-type backbone? Or what about Luvir with a Truvada backbone? So please vote. Okay, so many of you would actually opt in this patient in switching them away from the D4T, 3TC efavirenz to actually switching them now onto a dolutegravir-based backbone. As I mentioned, in the interest of time, I'm not really going to go through and discuss these, but it really was interested in hearing what your opinions are. And obviously, if we were managing this patient now, we would manage them differently to what we would have managed them at the time. Okay. So at the time, in 2010, what we would have done with the patients is we would have managed them according to the next set of guidelines, so the 2010 guidelines. And actually, this was fortunate timing for this particular patient because we moved him onto an Illuvia-based regimen. And because he had TDF and 3TC, well, this is what our guidelines would have suggested we would actually do according to what the backbone had been on in first line. Prior to this, in the earlier set of guidelines, the 2003 guidelines, in fact, any patient that moved from first line to second line tended to get a DDI AZT backbone with their Illuvia, so a much harder, much more complex, and much more toxic regimen than what we were using here. Okay, all right. So what we actually did was we switched this patient to we moved him onto Illuvia with TDF and FTC. And what you can see is that he responded well to second line initially. He had some decrease in his viral load. He had a treatment interruption from May 2012 to November 13, kind of disappeared out of the system, found his way back into care, restarted his viral loads with a relatively high viral load, and you can see he actually really just did not suppress after that. So he continued to have he suppressed he didn't really completely suppress at the time. We've got a mixture here where the viral load and the CD4 counts have actually been mixed up there, so apologies for that. And so how we define second-line failure in South Africa is there is a very specific algorithm which very much aligns with what WHO does, in fact. And so what we require for a patient to be considered failing second-line, currently they need to have been on their boosted PI for at least 1 year. Now we're at a period of transitioning and we're looking at whether or not based on data that we've seen from various cohorts in South Africa, whether or not in fact much resistance really does tend to occur in just 1 year on a boosted PI, and whether or not we should be looking at actually defining that as maybe 2 years on a PI before we would truly see any significant degree of resistance there. So what we look at is when we have that viral load of more than 1,000, we try and address as many of the issues as we can around adherence, around tolerability, check for drug interactions, make sure we've managed any co-infections, and try as hard as we can to address the psychosocial issues, which of course can be a challenge. And we would then repeat the viral load in 6 months, in the meantime monitoring things like pharmacy pickups, etc., and side effects. And then depending on what result we see after 6 months, we would consider whether or not to do a genotype. If they have that sustained elevated viral load, we would genotype them, and then on the basis of that genotype, we would pick a third-line regimen. So if you look here, we did genotype our patient, and what we saw is that he had a score of 120 if you look at Stanford. So his lopinavir score was 120. He'd been failing his PI for quite some time, and on account of that, he also had some resistance to darunavir as well. You can see he had some resistance to tenofovir, certainly a significant amount of resistance to AZT, and then also some NNRTI resistance that was actually still quite evident in his genotype and not actually archived. So what third-line regimen would you select? And again, bearing in mind that we managed this patient a little bit of a while ago, but you have more options now. So would you consider giving a dolutegravir with a Truvada backbone? Would you look at giving a triple nuke regimen? Would you look at giving darunavir and then give them with Truvada and raltegravir, or something similar with dolutegravir? Or would you give them dolutegravir with Truvada and etravirine? So please select just one of these. And again, when we look at your responses, we are looking for an opinion here. So we're not looking for what we consider to be a right or wrong answer, but just looking at some options. Okay, so most of you would have opted for a darunavir-based regimen with a 2-nuke backbone and adding dolutegravir to that. Okay. All right. Okay. So what we started him on was a darunavir regimen, and we gave a Truvada backbone, and we used raltegravir. Now, the reason we used raltegravir is that dolutegravir only became available for us in third line in July 2016. So at this point in 2014, raltegravir was the integrase inhibitor we were using in third line. And he tolerated the regimen pretty well, but as you can imagine, with the darunavir, with the TDF, the FTC, and the raltegravir, it's a twice-a-day regimen because he had some darunavir resistance there, so we would have been using that 600, 100 twice a day. The raltegravir is twice a day, so it's not an easy regimen to take. There's a significant pill burden there, and it's a twice-a-day regimen. What I didn't actually tell you about him is that now we're several years down the road. He's actually 54 years old, he's hypertensive, has become a diabetic patient. He's on different levels of treatment with metformin, requiring insulin. He's on an ACE inhibitor with a diuretic to manage his blood pressure problems. And he's become hyperlipidemic, so he's actually on a statin as well. So it really become a lot more of a complex patient, and we need to think about more than just purely the virus and how we manage that, but actually be looking at him a little bit more holistically and managing all of these issues, which we're going to be seeing increasingly with more and more patients. On account of the fact that his creatinine clearance has started to decline, so his renal function was impaired, most likely a combination of factors with the hypertension, the diabetes, and maybe even tenofovir playing a role there. So we modified his regimen slightly and replaced the tenofovir with a bacavir. But as you can imagine now, he's got all of those different ARVs, quite a complex regimen, as I already mentioned. He's now got all of the polypharmacy of managing his blood pressure, his diabetes, his hyperlipidemia, etc. So this poor gentleman is pretty rattling, and that's not just the end of his problems. As we started to look at his viral load, as we got towards the middle of 2017, we noticed that, in fact, his viral load had been creeping up. And we did another genotype, and we included this time looking at the integrase genes. And what we saw is a significant change in his genotype, and with there actually now being resistance to integrase inhibitors. So this is where we are with this patient, or kind of where we were with the patient, and I'm not going to talk further about the management of him, but I really just want to talk a little bit more about third line generally. So if we look at the third line in lower and middle income countries, by the end of 2016, there were close to 40,000 patients accessing third line therapy globally. And this is a little bit at odds. WHO had done some projections based on first line and second line failures and based on the scale up of viral load availability across lower and middle income countries. And their predictions suggested that actually around the end of 2016, there should have been closer to 61,000 patients. So clearly we are lagging behind, not only in third line, but obviously that comes up from higher in the cascade. Are we doing our viral loads at first line? When we're doing the viral loads, are we acting on them, or are we repeating them? Are we even looking at them? Are we switching patients to second line timeously? Once they're on second line, are we following them up, and are we doing our viral loads there, and are we doing our adherence interventions? Because really, when you look at where we are currently, we should have a higher third line than what we do. And what we have now projected towards the end of 2019 is that actually that number in adults should be almost tenfold what it was by the end of 2016. And this is with projections, again, assuming the viral load scale up across lower and middle income countries. In South Africa, we have the largest ARV program. We have more than 5 million people currently accessing ARVs. And even if you look here, you can see clearly we are underdiagnosing first-line failure with only 250,000 odd patients on second line. We are definitely underdiagnosing second-line failure and managing that. Since 2013, when our third-line program came into existence, we've only got 1,800 patients accessing third line. And if you look here, you can see that actually, even in Africa, there's a large number of countries who don't have access to any third line. And for many countries that may have access to third line, they don't have the luxury necessarily of genotypes. And in fact, in some countries, even viral load access may be a challenge. However, I am pleased to report that since I first started with talking about third line, etc., is that the number of countries with access to third line in Africa has increased significantly from about 6 to a substantially higher number. So if we look at this in South Africa, I mentioned to you we currently have about 1,800. What I wanted to point out here is that the third line uptake has been slow. And again, I think this is from a lag, a failure to actually diagnose first line failure, a failure to actually act quickly on first line failure, a failure to actually pick up second line failure, and again, a lethargy or a slowness in our reaction. But as I think word of our third line program and accessibility to the third line increased, you can see that we've had a definite increase. And year on year, what we're seeing is that we are having a more exponential type of increase in the number of applications we get for third line and the number of patients being moved onto third line. As we've seen this increase, we've looked at how in the future, if the projections of WHO are accurate, and we should have this relatively massive increase in second line and third line, although a lot of this may be mitigated by the rollout of dolutegravir, the question is, are we going to be in a position where third line becomes difficult to manage? In South Africa, we have one national committee that reviews all the third line cases, and that's fine when you've got 1,800 patients over 5 or 6 years. But if we start pushing our viral loads and actually start getting the first line failures, getting them onto second line, getting the second line failures and moving towards third line, is this going to become a task that is too big for one central committee of experts? And so the question is, are there ways to task shift? And one of the developments we have with that in mind is the development of this algorithm, which looks at the genotype, and depending on what those scores are, determines a regimen. And we are about to we've written up the first year results from our third line program, and we're about to analyze the data to actually see what are the outcomes once you introduce the algorithm. And we've actually had relatively good results in terms of the outcomes, although we have relatively high PI resistance going into third line, which is what you would expect. We've actually still had relatively good responses with 83% of patients suppressed to less than 1,000, so using WHO cutoffs there, and more importantly to less than 400, close to 80% there. And this was in the first year of our rollout of third line. So a time where the patients coming into third line were pretty ill patients who had been waiting and been left on failing second line regimens for a substantial amount of time, which may have impaired or affected their response to third line. So just to finish off then, looking at the dilemma that our patient is, he's developed a whole lot of comorbidities, and like us, he is growing older, he's developing non-communicable diseases, which we know are the next big thing, not only affecting our HIV patients, but affecting the populations in Africa generally. He's now at a situation of polypharmacy, and what we are doing is we're adding more and more drugs for the comorbidities, but we're also having to add drugs in terms of managing the HIV infection. He now has a resistant virus, which has high-level resistance against all the integrase inhibitors, including dolutegravir, so not many options left for him. And in fact, in South Africa, third line is kind of where it ends. Beyond third line, we have to revert back to the old adage of we manage him and keep him on the regimen that he's on and do our best to keep the virus as low as possible and hope that the immune system holds in there. So I want to just say a brief word of thank you to the South African National Department of Health, the Third Line Committee, for providing access to some of the patient data and also just the general data that I've presented there. I also have a question that that was given to me by somebody from the audience. And the question here is, what is the experience and the reasons for darunavir as a second-line PI instead of lopinavir or atazanavir? So in terms of the South African experience, we are not using darunavir in second line. We do recommend it. We've got two sets of guidelines. We've got the public sector guideline, and then we have the Clinician Society guidelines. Now, the Clinician Society tends to produce a guideline that is meant to straddle both the public and the private sector, because we recognize that in South Africa, many patients may be employed today and have a medical aid. They may lose their job tomorrow, lose their medical aid, and then they have to transition into the public sector. And we know that, of course, every time we start changing a patient's regimen, we put them at risk of virological failure. So whereas in the early days when we started treating HIV, we had the Clinician Society guidelines, which were here, and the DOH guidelines, which were there, nowadays, in 2018, 2019, our guidelines sit much closer together so that patients can transition between the two sectors without too much disruption and being able to access similar regimens. However, the point that I want to make is that in the Clinician Society guidelines, although a lot of the patients are managed with Eluvia, we do actually have the option of moving darunavir as our preferred PI in second line in the Clinician Society guidelines. And this has really been around the fact that we know that darunavir as a PI is a lot better tolerated than lopinavir is. Of course, the challenge remains for us the inability of being able to dose darunavir with TB treatment. Again, though, as we're starting patients on treatment earlier and earlier, we're seeing less incident TB, and we do use a lot of IPT within our regimen. There was a study that was initiated recently which was trying to iron out whether or not we can work out what the dose should be of darunavir with rifampicin. It was called the DARIFI study, but unfortunately, several of the patients in that developed quite a severe hepatotoxicity, and so the study was stopped. So it looks like in terms of TB and PIs, we're going to be stuck with using Eluvia and double dosing that with no real answer to that. I think another thing to bear in mind is there was a study, the WRHI 052 study, which our group was involved with, and what that study did was it took patients who were already on Eluvia and who were virologically suppressed and switched them, randomized them to continue their Eluvia or to be switched to darunavir, but used at a very low dose of 400 milligrams of Eluvia once a day with 100 milligrams of ritonavir. And basically we showed at 48 weeks the non-inferiority of that low dose of darunavir compared to Eluvia. We kept the backbone the same for the patients as they were suppressed. So this is possibly an option for us in the future. But again, this was purely a switch study and doesn't tell us whether or not you could use that low dose in switching from first line to second line. So that is our experience in South Africa of using darunavir as a second line. So in the public sector, no, it's not something we're doing, but we have done a study, and in the private sector, it is probably our preferred PI for second line there. Then there was one other issue that I wanted to address, which I actually think Professor Levine covered nicely. I had just wanted to talk about how we were doing sequencing in the pediatric patients, so I think that was pretty well covered there. So thank you very much. I don't know if there are any questions.